1 out of every 15 babies born in South Africa will die before the age of 5. That translates into the death of over 200 children every day. We have no idea how many of these deaths are because of tuberculosis, because too often in children, the disease goes undiagnosed and untreated. In a country with the 3rd highest burden of TB in the world, these are the forgotten children. Three years ago, Bonke was diagnosed with tuberculosis, and he's been battling with the disease ever since.
TB, what it doing inside your body? In your lungs, you feel, you take a space in your lungs. Sometimes you feel sick. Sometimes you coughing too much. All the time. Yes, you're scared when you're sick. Because not playing, not talking, you feel sick, you feel like vomit. Sometimes you feel like want to sleep.
Children with TB get a cough and night sweats. They're feverish and lethargic, symptoms which can easily be confused with other common childhood illnesses.
Tuberculosis, or TB, is one of the top 10 causes of death worldwide. In 2017, 10 million people contracted TB and 1.6 million people died from this disease. Of those that contracted the disease in 2017, an estimated 1 million were children, and 230,000 of them sadly died of this disease. South Africa is one of the countries with the highest burden of TB, with an estimated incidence of 322,000 cases of active TB in 2017. Now, TB continues to be the leading cause of death in South Africa. In 2017 alone, 22,000 people died from TB, and an estimated 56,000 with both HIV and TB died. Now, much as TB Awareness Month and World TB Day is celebrated on the 24th, and the theme for 2019 is It's Time. It's time to keep the promises made at the United Nations High-Level Meeting on TB. It's time for a world without TB. It's time to treat 40 million people affected by TB by 2022. It's time to know your TB status. So today we discuss tuberculosis, known as TB. We'll be joined in studio by a pulmonologist, then the Director for Drug-Sensitive TB from the National Department of Health, the Head of the Center for Tuberculosis and WHO SRL from the National Institute of Communicable Diseases, or simply NICD. And we also have a National TB Ambassador who's cured of TB, who will be sharing his story with us. You can tweet us at SABC Health Talk, or simply just interact with us on our Facebook page, SABC Health Talk. So sit back, relax, and learn from this bumper show, coming to you just after a short break. I'm Dr. Sello Mutau, and this is Health Talk.
When I'm dancing, I get to express the truest version of myself. It's electrifying. My name is Courtney Paul. I'm a choreographer, DJ, and I do my passion for a living. I grew up in a predominantly colored community in Durban, not very privileged, but it was quite normal to see girls in my community pregnant. I felt like once girls felt pregnant, there was nothing left after. It now became a battle for survival. How are we going to afford this new lifestyle? Watching things like that always made me feel there is more I want out of this life. Being a professional dancer, my body is so important, which has led me to make the decisions that I have and be as safe as I possibly can. When you're in a relationship, the condom conversation can often be tricky. But in actual fact, I'm just trying to protect myself. And if you love me, then you should love me enough to protect me. Condoms give me peace of mind, so I can live my life with no regrets.
Use a condom. Have peace of mind. Hashtag no regrets.
On Trends Travel, we bring you a full guide on all things lifestyle related. With so much to discover, we give you comprehensive reviews of places to visit, music, travel, and food. We also explore the arts, whether on or off stage. All this and more. Be sure to tune into Trends Travel, Saturdays at 5:30 p.m.
My name is Turbercolosis, and I'm staying at Kailicha, and I'm at Joslow High School here in Kailicha. I'm 18 years old this year. It was 2016 February when I was diagnosed with XDR TB. When I started coughing, and then my grandma thought it was best for me to go to the clinic and got checked up. And it was on my chest, coughing and sweating a lot. But the doctor told us that it was XDR now, not MDR. So yeah, it was devastating.
Now we sit down, and then they said there is a new tablet which is Stalamat. They said they're going to put Snetemba in that study. I said no, everything is fine. Whatever they want to do, if it's going to save the life of Snetemba, I don't mind. We tried everything, and then when the time goes on, we saw Snetemba that she's happy. And every time I used to say, Snetemba, you must admit me that you are sick, but you must say that the TB won't let you down. You have to govern the TB, not the TB to govern your body. You must be strong for your body.
I would like to say that the government should give a lot of people this tablet, and that it should not only be in Kailicha but all over the provinces as well, not only in Western Cape, because there are a lot of people who don't get this chance to take this tablet, and they suffer. A lot of people die, so I suggest that the government should buy this tablet so that everyone should get a second chance to eat.
Okay, so let's learn more from our guests about this condition called tuberculosis or TB. First up is Dr. Murumisi Mukansi, who's a pulmonologist and head of ICU based at Helen Joseph Hospital in Johannesburg. Welcome to Health Talk once again, Dr.
Good morning to you and to the listeners and the viewers.
All right. And then, of course, we have Dr. Lindiwe Mvusi, who's Director for Drug-Sensitive TB from the National Department of Health. Welcome to Health Talk, Dr. Mvusi.
Thank you for inviting me.
All right. We also have Prof. Nazir Ismail, who's head for Center for Tuberculosis and WHO SRL from the NICD. Of course, you'll tell us what this WHO SRL is. Welcome to Health Talk, Prof.
Thanks a lot. Good to be here.
All right. So let's start with you, Dr. Murumisi. Just in case there are people there who are hearing about this word TB for the first time, what are we talking about?
Basically, we're talking about an infection of mainly the lungs, but can affect any part of the body, which is in full called tuberculosis, caused by a bug called Mycobacterium tuberculosis, which it's really picked up by droplets. So as you sneeze or cough, the droplet move in the air, and then the next person can obviously pick it up. Much better when there is no light, so in darkness, and in closed spaces where there is no ventilation.
Okay, all right. So Dr. Mvusi, in my introduction, I mentioned some statistics in South Africa. You know, we mentioned figures from 2017. How serious a problem is it in South Africa? What's the load of TB like?
It's quite a serious problem in that over the years we've been reporting more than 200,000 people who have TB in the country. And South Africa is also one of the 8 countries who are contributing 2/3 of the total global burden of TB. If I can put it in terms of how much South Africa is contributing, it's about 3%. So when you actually look at the population of the country, we have a huge burden of TB, and it's mainly driven by transmission, as it has been mentioned. And the other problem is that by the time people develop symptoms, they already have disease and already transmitted the infection to other people. So if we need to end TB, we need to prevent the transmission of TB, as well as identify those who have TB and put them on treatment.
All right. I'm going to come back to you because, you know, would like to know exactly what the department's plans are in combating this condition. But let's move on to Prof. Now, Prof, firstly, tell us about, you know, your role at the NICD. We read that long introduction about WHO, SRL, and so on. What do you guys do there about TB?
Okay, so two primary functions. The NICD is first surveillance for TB, and public health responses related to that, so monitoring the burden, changes, etc. And the second important function is reference microbiology. So we study, as Morumutse has indicated, the bug that's causing TB, the infectious agent. So we do a lot of specialized testing for it, and also guide the policies for diagnostics in South Africa.
I see. All right. So let's come back to you then. We mentioned, you know, I think Dr. Mvusi mentioned symptoms, by the time symptoms develop and so on. What are the typical symptoms, as it were? Or what are those signs that people should look out for and say, this is time for me to go and seek help?
Basically, it's cough that's productive, maybe productive of sputum, and maybe over a long time and not abating with a treatment for flu and maybe those type of infections. And the other thing, there may be loss of weight, and there may be night sweats. Now, we don't mean just sweating, we mean drenched up in sweat. When you wake up, you have to change your clothes because you're wet. So we call that constitutional symptoms of TB.
Right.
And having said that, it also depends on where TB is in the body.
Right.
So if it's in the lung, other additional things would be chest pains and stuff. If it's in the tummy, there may be changes in the bowel habits or anything that is really protein from there. If it's in the brain, it may be that you get confused and maybe sleepy and headaches. And it may be taking other parts of the body as well, not as commonly as the three that I mentioned.
So TB can actually affect any organ in the body, not just the lung?
It can. The lung is just the entry route.
All right. So it starts in the lung, as it were, and goes to other parts of the body as well?
That's it. That's
right.
it.
So, Dr. Mvusi, let's talk a little bit about transmission. You know, we spoke about, he spoke about earlier that people get this from the air, you know, if there's somebody in the room with people with TB, of course, infected. And if you breathe in, you know, that air, you get the disease yourself. Let's talk about those conditions that promote spread and contraction of TB.
Mainly the high-risk groups for acquiring TB infection and disease are people who are immunosuppressed, mainly HIV-positive patients. That's the bulk of patients that we are seeing who acquire TB, about 60%.
Yeah.
And other conditions include diabetes, especially uncontrolled diabetes, patients who are on steroids for a long period of time, patients who are in chemotherapy for cancers. And we also see it in mainly children less than 5 because they don't have a strong immune system at that point. And again, in people who are smokers and people who are abusing alcohol. Yeah. Most of the time we find that in those groups of people we can still prevent TB. They may be infected, but we prevent the development of TB disease through treatment that we provide for a certain period of time. But it's not necessarily meaning that they cannot be infected again if they are exposed to a person who has TB. Okay. So the main thing is that we need to prevent the transmission so that we then cut the cycle of infection in the community.
So, I mean, TB has been with us for many, many, many years, you know. What are the current challenges? Why is it that we can't get to grips around, you know, either wiping it out or just, you know, controlling this condition?
Well, one of the challenges that we faced was the increasing HIV epidemic, but TB is also driven by poverty, so it's also a social disease. Right. We can treat people, cure them of TB, but if they go back to the same living conditions that they are in, then they are still going to get another episode of TB and come back to the clinics for treatment. So we need to address it holistically by making sure that we improve the living conditions, address the unemployment, the areas, if you look at informal settlements, which are a hub for transmission because of overcrowding, poor ventilation of the houses in that setting. And the only thing we can then do is just to address those socio-economic
From NICD's perspective, I mean, what are the challenges with TB generally?
So I think, as indicated, I mean, it's dependent on symptoms that you'd come forward and get tested. But the challenge that you have with symptoms is that sometimes it can be very vague initially. So just a cough.
Yeah.
People think it's the flu or something of that nature and don't bother to come forward and get tested. And the problem is if you have TB and you have delay in seeking care, it can transmit in that period of time. And the later you delay it, the worse your prognosis would be. So as it becomes more advanced, it makes it more difficult to treat and cure. So I think that's the one important issue. The second thing, I think, as Lindy has pointed out, poverty is a major challenge that we face in the country. But I think also it's important to appreciate that TB occurs in many environments and in different populations. So whether rich or poor, you can still get TB exposed in many different ways, whether it's in the work environment or whether it's at the shops or wherever it is. So for me, the key message is that really early presentation and you know, I mean, it's something that occurs commonly in South Africa.
Yeah.
And presenting early and just getting tested, it's free in the state sector, and we have top technologies.
Actually, we're going to be talking a lot more about that,
yeah,
you know, later on to say,
yeah,
you know, how do we prevent and how can we get more people to screen for TB?
Yeah.
Okay, on that note, it's time for a quick break. When we come back, we carry on with our story on TB. Please stay with us.
In a UN report, scientists say climate change is getting worse.
1/3 of our food sources for the population come out of the ocean.
We spoke to people who have been directly affected.
We have lost a lot of cattle. Gemsbokvlakte, Tosca gebied and Jakkalskop. Everywhere you will see there's animals dying.
I've lost 2 of my cattle this January.
Africa's demand for clean drinking water is rising.
Drinking water is a top priority.
The next day when the water comes back, it's dirty.
I have implemented a level 5 water restriction, effective immediately.
Environmentalists seek solution to preserve the planet.
This is Cape Kirpa, which is also one of the endemic species that is only found within the Western Cape, so it occurs nowhere else in the world except in our water systems.
Years go by and new faces are born. New villains and new drama queens. We look back and reflect on the memories that serve us. A tight bond molding us together, creating stories that will last forever. Make your evenings memorable. Weekdays on SABC 1. Mzansi for sure.
Hey, it's Reno Race. Would you like to renovate a room in your house? Then don't despair, because Metonoya, Tina and their team of helpers are on the rescue. There'll be some silliness and a lot of running. But most importantly, it's out with the old and in with the new. Joy! Reno Race, Wednesdays at 6 p.m. only on SABC 1. Mzansi for sure.
It was a journey of self-discovery.
It started as a call to adventure.
Some of us leaped at it, some of us refused the call.
But inspired by our ideas to make Mzansi better,
we all crossed the first threshold.
The final 6.
The road of trials began. Not only were our ideas tested, we were tested.
But on a mountain of truth, you never climb in vain. We embraced our shadows and conquered our fears.
It was no longer about us. We discovered our essence in selfless service. From the judges, I learned an unwavering steadiness of purpose to look to nothing else, not even for a moment,
except to reason.
Leadership is not about the next election, but about the next generation.
From one day leader,
we learned
and we became.
One Day Leader, Thursdays at 9 p.m. on SABC 1, Mzansi for sure.
Okay, welcome back. We continue our story on TB, and to learn more about its impact and resistance of this organism, we still have our guest, Dr. Murumisi Mikansi, a pulmonologist and head of ICU based at Helen Joseph Hospital, Prof. Nazir Ismail, head of Center for TB and WHO SRL from the NICD. And now we're now joined by a special guest who's a national TB ambassador, and this is Thabo Pilisane. Thabo, welcome to Health Talk.
Thank you very much, and hello to all the viewers at home.
Okay, let's stay with you for a while, because Dr. Murumisi, I'm going to come back to you about the impact on the health system, on the individual, and so on. But let's just get your story, Thabo. You were diagnosed with TB.
Yes, that's correct. I was diagnosed with TB at the age of 13, and at that stage, I was still little in 1989, and the number of pills that one used to take, there were some reactions on my body where sometimes I would feel a bit itchy, but also the issue of stigma as a young boy, I would skip treatment to such an extent that unfortunately TB came back out of my era of defaulting for a number of reasons. Yes.
Right. So you found it difficult to stick to treatment?
Definitely, yes.
Right, and I suppose one can understand. I mean, you were 13 years old at the time, and it's quite difficult. Did you have any idea about how long you were expected to be on treatment?
Well, I was informed that it would be for 6 months. Yeah, definitely. But the other thing, it's at that stage, I used to take TB lightly, like it's flu, or until such an extent where I learned the hard way in 2008.
Yeah, tell us about that. What happened?
Yeah, in 2008, while coming from work, I could smell blood in my mouth. I took it lightly. I went home. After a few hours, when I was spitting out, blood came out. I was rushed to a local hospital. The next day, they did a bronchoscopy, which revealed that I had some cavities on my right lung. Yeah, and I was put once more on the treatment again, and that's when I realized that this is a fatal disease if one takes it for granted.
So this was the second time now that you had TB?
Actually, it was the 5th time.
Right.
Yeah.
Okay.
Remember, previously, look, I have got my siblings and even both my parents who were also diagnosed with TB. So at that stage, when one of the family members was diagnosed with TB, there would be no effort to go and check if, whilst you were not on treatment, you have not yet maybe infected any other family member. So things were just as normal. But I'm glad that today I'm standing here as a survivor for the past almost 14 years, since 2008. Yeah, when I decided that this is my life, I have to take responsibility of it.
Okay. So you started sticking to treatment at the time. The 5th time?
Yeah.
All right, okay. Maybe, I think it's on that point that perhaps let's just understand the clinical nature and the cause of this disease. What actually happens? I mean, he's I think, brought out a very practical and real issue out there.
A lot of things can happen, and I think one of them is repeated infections. Obviously, the other challenge that we have is that the treatment is 6 months at least or more. And that's a lifestyle. It's no longer treatment, because most things in a week we sorted, and to be compliant during that time is a challenge. And with that comes the failure of the treatment, and also the resistance to the treatment, and also that we forget. So those are really the simple challenges in terms of treatment when the diagnosis has been made. But having said that, it's also not easy most of the time to diagnose it, that you won't necessarily find it with a spit if there is no communication with the air passage and it comes out and you can get it. Or if it's in children who are not able to cough and give you the specimen. So a few other things have to be done, like confirm it with X-ray, and then maybe do a bronchoscopy if there's an area of a lung that looks like There could be TB, but it's just not coming out, so you wash it out with saline and send the specimen, or take a biopsy as well, because then the next other way to diagnose it is with the help of the pathologist, that they will see TB changes in the specimen that you're sending.
Right.
And obviously, you can lose blood and be anemic. You can bleed for several reasons that perhaps we don't have time in the show to discuss, but one of them would be the cavity that develops may easily erode the blood vessel, especially the artery, and then you start bleeding. And that's perhaps what happened in Tabo's place.
Right. Prof, you mentioned, the whole notion of resistance now. Just tell us about, this notion of resistance, because we've heard about MDR-TV, XDR-TV, and so on. How does that develop?
Okay, so usually there's two ways that you can get drug-resistant TB. The first is usually through acquired resistance, and that sometimes, I think, as our TB survivors indicated, sometimes you take your medication and it's erratically taken. So the organism starts developing, adapts to the drugs and becomes resistant to them. And that can lead to what we call acquired resistance. And then obviously the first line treatments don't become effective. The other method is usually sometimes the person that has drug-resistant TB, for example, in the homes that we just heard of now, and if that's not picked up early and not managed, then the person could get primary transmission of drug-resistant TB. And we see equal amounts in the country of both types. In terms of the burden of that disease, we did a national survey, a massive survey to determine the burden of drug-resistant TB, but also second-line resistance. On average, about 5% of all TB cases have drug-resistant TB, either rifampicin or MDR-TB. So just to go back to the definition, so it's a bit complex in terms of the definitions, but fundamentally the key drug, we use a 4-drug regimen for treating susceptible TB, and the key drug there is rifampicin. And once that drug is lost, then you're no more treated for a 6-month treatment. You got to change to a drug resistance regimen. And M and XDR are just more resistant forms of that. But coming back to the issue of rifampicin resistance, the prevalence is about 5% nationally, meaning that out of 20 patients that have TB, 19 would have drug susceptible and you can take your standard treatment, but 1 out of those 20 people would have drug resistant TB and require a longer regimen. But I think what's very welcoming, I think, with drug-resistant TB, when we did the survey initially, we found massive amounts of second-line resistance, meaning the therapy would not be effective. And South Africa has really made strides, major strides in the past few years, adopting new regimens, and actually radically changed the way treatment is done for drug-resistant TB. So, I know in the community, they call it big TB, because of the injection, and people are afraid of that. And we've moved to an injection-free regimen and actually trying to push it shorter to 9 months from 18 months. So I think, we've gone a long way in terms of being able to provide the most effective treatment and the most patient-friendly treatments for drug-resistant TB. And it's not that common, but the biggest challenge, as I mentioned before, we need to detect it early so we can stop transmission. And it was an interesting study looking at, how transmission occurs and how it's prevented with treatment. And they did this at the Witbank facility, and what was fascinating was that patients that were put onto drug-resistant treatment that had been diagnosed with drug resistance, the infectiousness decreased by 90% in 48 hours. So it really tells you that these drugs work effectively. You can actually stop transmission and help people very rapidly, and the infectious risk goes away.
Maybe coming back to the infectious nature of the condition, we've heard from Thabo basically around the concern that if he's got TB, he might infect others. When and for how long are people continuing to be infectious? When can they, how long can they spread the disease for, in terms of starting treatment?
Obviously, if it's a drug-sensitive TB and it's on treatment, within 72 hours you have killed them, though the mycobacteria, though they still remain in the specimen for up to 2 weeks or even longer. So in that way, in about 2 weeks, you're safe to mix with people. But the problem, like Nazir has said, the spread happens before you know about it. So most people have picked it up by those that are in the close household contact by the time that you realize you have a disease and TB. So that may just be the challenge.
Can we just Coming back to your issue now, did you have, let's call it ordinary TB, or was it resistant TB?
I was one of the few fortunate. I had an ordinary pulmonary TB.
Right.
And though I was on streptomycin 3 times, you know that injection that you have to go for 40 consecutive days to your clinic.
Right.
Sometimes it becomes a bit unpleasant.
Yeah. I suppose an injection would be unpleasant for most people. All right, it's on that note that we'll go for a quick break. When we come back, we'll continue our discussion on TB. Please stay with us.
Munganano FM Xitsonga Music Awards 15 Winanga Mfuna Nthabuko Daro Tatpirana Hina Tinkampi Tinsadaka Dr. Thomas Chauke Benny Maingane Chauchirimane General Muska Antonio Marcos kutoka Mozambique Sunplan Questa Pastor Lungintala The Living Rock The DJs The Munganano FM Number 1 Butana Kuma Ticket Copy Ticket Shoprite na Checkers 150 Ramana Mani Golden Cycle 300 Rand VIP 1000 Rand Hashtag Axma 15 30 March 2019 Ekiana Stadium Takusamfuma Ulo.
A royal welcome, please, for a regal southern songstress, Yvonne Chaka Chaka.
When everybody wanted to be doctors and nurses, I stood up and I said I want to be white.
Oh.
The late Joe Slovo called me the Jewish Zulu. I think it's very sad these days, for a long while, that a lot of women
blame this on the guys, because this is a plot by the women against the women.
We are socialists. Yes, sure. All of us.
Be intrigued by hitting topics on the couch with people of the South, and stay cultivated as they grace you with cultural entertainment at its level best on stage. Make a date with Dali Tambo as he profiles everyone from all walks of life on SABC Encore DSTV channel 156.
We've heard it many times from female entrepreneurs that they aren't taken seriously, and Future Females is a worldwide network of women.
So we're creating a platform where these women come and they collaborate and they meet each other.
Have the Civil Aviation Authority announced when they'll be making some announcement with regard to findings?
The Chief Executive Officer of Ethiopian Airlines, he said they do not even know the magnitude of the situation.
Bring us up to speed with regard to the latest developments.
We now know there was a football official, there was a journalist, there were university professors.
Koko said his hands are clean and his detractors have ulterior motives.
South Africans have been solely done that Machela Koko had conflict of interest.
Our election website here on SABC is now live.
Right, so welcome back. Having understood, the nature of this condition, we're now going to talk about perhaps one of the most important aspects of our talk today, and that is, how do we prevent this condition, and how do we find more people that we can screen for? We still have our guest, Dr. Muramis Mukanzi, pulmonologist from Helen Joseph Hospital, Dr. Lindiwe Mvusi, Director for TB Sensitive from the National Department of Health, and of course we still have Thabo Pilisani with us, who's a National TB Ambassador. All right, so perhaps let's start with you, Dr. Mvusi. The department's plan now in terms of prevention and screening, are there programs in place?
Well, yes. One of the things that we looked at was that looking at the numbers that are reported on an annual basis, the numbers tend to be coming down. And in 2017, for example, we reported about 227,000 people who had TB. Now, the concern was that we are missing quite a number of people in the system. It's either they are not coming to the clinics or they are coming to the clinics and not necessarily screened and diagnosed with TB. And this is what is causing the transmission in the communities. So one of the strategies, therefore, was that we need to find those people who are out there, have TB but are undiagnosed, to prevent them from transmitting. And then the other strategy was related to the 90-90-90 strategy, which is similar to the HIV strategy, which mainly looks at those that you have diagnosed with TB, ensuring that you are linking them to treatment, and when they are on treatment, also retaining them in treatment until they complete their treatment. So the missing patients or who have TB, we have estimated the numbers based on the estimate from WHO in terms of how many people we should be reporting on an annual basis. And we found that we're missing around 160,000 people who are out there. Yeah. Some are diagnosed, others are not diagnosed with TB.
Yeah.
So we need to therefore come up with a strategy to find those. Yeah. So that's one of the campaigns that we are now running to ensure that everyone who presents to any clinic or hospital is screened for TB and tested if they have symptoms for TB.
One of the major problems, discussed recently, and in fact, it's an old one, is around migrant labor, the migrant labor system. That people perhaps get infected at some remote area and come to the cities and present with the condition, but the primary source is not then addressed. How are we dealing with that? Or is there improvement at all? Or, I mean, is it still a challenge?
It still remains a challenge, because what we find is for people who are diagnosed in the major cities, for example, they come in, live in informal settlements, some visit relatives, and some just come for health seeking, basically. Now, when they get there, they give wrong addresses. And now the problem is, if they are diagnosed with TB and we need to find them to start them on treatment, we can't find them. And it's very difficult to then track where they are. One of the things that we're trying to do to strengthen that is to educate patients in terms of why we need them to provide us with the correct addresses and the telephone numbers. Secondly, we have the migrant labor system where, for example, when you look at Northwest and Northern Cape, you find that in the farming areas, people migrate across provinces. And it then becomes difficult to track them if they are they've missed appointments in a clinic. So it requires that we work with the different provinces so that those patients are kept in the system. But it also comes back to the responsibility by the patients themselves to ensure that wherever they end up, they go to the nearest clinic and present themselves there for continuation of treatment.
What about across our borders? I mean, some of them come from Lesotho, Zimbabwe, and some of the neighboring countries.
Yes, those mainly, for example, are from the mining industry, where we've got now partnerships with the mining industry, where people who move across borders, they are properly referred, and the follow-up is done to make sure that they get the treatment.
Yeah.
So we communicate with the program managers in those countries so that they are able to then track those patients.
All right.
It still needs a lot of work, but a lot has been done to try and address that.
Okay. Dr. Muganzi, let's just talk principles of prevention and screening. I mean, we've been talking a lot about screening as in finding people to screen. Just the basic principles around prevention. Somebody watching this program will say, okay, so what do I do to ensure that I don't get infected by TB?
Well, it's like we've had the discussion, most of the problems are really economic and they have to do with poverty. So obviously, if we could eat well, that would be one thing. If we could, when we know that we're exposed to TB, and present to the healthcare facility so that if ever we perhaps immunosuppressed, then we could be given prophylaxis. So INH is one of the medicines that we have used to prevent TB, and to try and also encourage those that are around us to take treatment adequately and properly, so that
our neighbors, relatives,
and relatives, and maybe present to healthcare facilities to be checked if there is any symptoms, as Lindy has said, if there is symptoms that may be indicative that you have TB, because as you see, most of them are easily symptoms of other diseases, but you have to have them excluded. And
Thabo, your role as an ambassador, I would imagine you talk to a whole lot of people. Just tell us about what you do.
Well, firstly, I need to applaud our Honorable Minister, Dr. Motsoaledi, for having appointed us as TB ambassadors. Well, personally, in my hometown in Klerksdorp, every year on the 21st of March, I organize a fun walk which is a lifestyle activity that attracts a lot of people. And at the same time, we have the Department of Health, your ORAM and other stakeholders, where every attendee would be given a platform to go and test to do some screening for TB. And I have been invited in various workplaces, your mining areas, as I'm from the Northwest. I've been to Rustenburg, I've been to Val Reefs, where I was able to speak to mine employees, specifically men, because as we so reluctant to go for screening, for HIV tests, there's an element of self-diagnosis. Sometimes we prefer that there's a pain, then you go over the counter instead of going to a doctor and to know the condition of your system so that you know what are you fighting exactly.
And what sort of discussions ensue when you talk to people? I mean, do you find that there's lots of misunderstanding, myths and so on around the condition?
Certainly there is. There are so many myths that are being spread around because people think only people from poor families are at the risk of TB. We have the Prince, he's the son to King Zwelithini. You have Miss Gary Elson. She has always been a well-known TV personality. So anyone is at risk. But the most important thing, it's people who get advices that if you go to a certain church, the pastor will pray for you, stop the medication, which is something that I've picked up from some of the people I've interacted with. The usage of your traditional herbs, which sometimes it has been a misleading effect. I always encourage people, listen to your doctor, go to your nearest clinic, and then take your entire treatment until you get cured completely.
Well, Thabo Philizane, our ambassador for TB, thank you so much, man, for your time, and we can only wish you well, and please continue the good work.
Thank you very much. It has indeed been a great pleasure for me to be here.
All right, time for another break. When we come back, we wrap our discussion on TB by looking at treatment. Please stay with us.
Congratulations to Emoyeni for its achievement at the 13th SAFTAs.
Like a shooting star, I go. Like a shooting star, I go.
Phambili wendaba zosaziwayo ukhona to turn that frown upside down.
We'll agree that the best way to spread a story is to include more people.
Get obsessed with the best of the best when it comes to Unkosi. Catch RGB Saturdays at 7:30 only on SABC 1 Mzansi for sure. Prime Time is the definitive show that brings you the lowdown on cinema. Music. Art.
Recently, 50 makeup artists from around the country watched their art pieces grace the stage in the annual Fantasia body painting competition held in Johannesburg. The results quite revealing.
And sport.
Drop and goal is good, hits the post. Heller goes himself, and it will score. Oh, what a try! Magnificent play from the Australian 5'8".
Catch Prime Time on SABC Encore, DSTV Channel 156, Timeless.
I'm Dr. Anya Reuter. I'm working for Doctors Without Borders in the drug-resistant TB program that we have here in Khayelitsha. Tuberculosis is a big problem in adolescence. It's one of the biggest killer that we see in kids. And being diagnosed with tuberculosis can really lead to a lot of stigma. Often children will need to stay out of school initially when they're infectious, and so that can lead to alienation from peers. It can lead to stigmatization from family, from their friends, and also especially if they're diagnosed with something like multi-drug resistant TB, they need to take a lot of tablets with very toxic side effects.
It's
not a good experience because you don't feel right. At the same time, you just say, no, you just take it as time goes, and you also learn to expect it because you want to live. You also have a family that loves you and support you. So to say you must take your pills, and don't forget that they take them, because you might never get a chance to take them again.
Often the adolescents are very motivated and are really brave in taking their treatment. Often a lot braver than us adults. I think they complain a lot less. And we've really seen how how support groups, how they can support each other. And I think that's where patient support comes in for youth.
Yes. And also my counselors have been with me. You can talk to them anything that you want. They are supportive, they don't judge you. They are with you every step of the way.
Okay, welcome back. We're talking TB with our guest, Dr. Mromisi Mukansi, pulmonologist from Helen Joseph Hospital, and Dr. Lindiwe Mvusi, Director for Drug-Sensitive TB from the Department of Health, and of course, Prof. Nazir Ismail, Head of TB, WHO, SRL from the NICD. All right, so gentlemen and lady, let's talk the principles around treatment. We've already introduced the whole concept that, you know, this is obviously a condition that requires treatment for a long time. Just take us through the principles around treatment from the condition.
I think the principles basically it's to be compliant, to take the treatment for as long as the 6 months at least to the 9 or 18 months that you have to take. And what then the healthcare facilities could support you with, it's programs like the direct observed therapy, that they see that you're taking the tablets.
Yeah.
Because sometimes people may take the tablets, but it doesn't mean they drink the tablets when they get home.
Yeah.
More so that it's a marathon, the 6 months. It's not a sprint that in a week's time you will have finished your therapy and then you move. So, and also to present yourself for a confirmation of cure whenever you have finished your therapy so that you can move on and to have the other people checked. In that way, I think we will have sorted it out.
Is it still a handful of tablets, or is it, you know, is it gone easier now?
Well, when I was a young student, they were 13, at least for the drug sensitive, but they've now made combination tablets,
right.
So we're down to 5.
Right, down to 5,
yeah,
okay. Yeah. And perhaps from the department's point of view, how are we doing in terms of treatment, generally?
Well, we're doing well and not so well, if I can put it that way. For example, we are improving on drug-susceptible TB in terms of treatment success. We're at 82%, but we're still struggling with drug-resistant TB. For example, MDR, we're about 55%. We're hoping it will improve with the introduction of new drugs. And for XDR, we're at about 43%. So we still need a lot of work to improve, whether it's introducing more better drugs as we move ahead or ensuring that patients actually adhere to treatment. And one of the strategies that we intend to implement is the adherence strategy, using the same model as for HIV, because most of the patients are co-infected, and we understand that the pill burden is even more if you're on ART as well. And just to try and educate patients about side effects so that if they have any side effects, they need to report them and that they can be managed, because that's what discourages patients as well from continuing with taking treatment.
Talk about side effects. What should they be looking for?
Obviously, it depends on which drug. For instance, if you're taking rifampicin, the redness of the secretions, it's good because we know you're taking the medicine, so it's redness of secretions. If you have contact lenses, you must be wary. And with it, you can have the liver failing, so liver problems will happen, and maybe kidney problems, to say a few. And with INH, similar things happen. There may be, in addition, skin infection, skin rashes, and the liver, and that is also affected. With ethambutol, you must worry about the eyes, so you must have your eyes checked if you think there is anything. And the pyrazinamide, has got the same, the liver, the skin, and the kidney may be affected. So that's in short. But the redness of urine, we like it because it tells us that you're taking the medication.
Right, right. Good. But in short, I mean, we're saying the main message is that the side effects can be sorted. From your perspective, perhaps you'd like to comment on treatment and its successes and challenges.
Yeah, so I think there's a few issues around treatment. So the one is the side effects, and I think we shouldn't shy away from the fact that there would be side effects. And I think it's important that family members, co-workers, etc., are empathetic to such patients. I mean, they've come through a difficult patch to get a diagnosis of TB and they need to be cured. And I think our TB ambassador is a very good example. I mean, the first few months are often difficult for patients because it's what we call the intensive phase of treatment. So it's more drugs that patients are being administered. So I think just a bit of empathy from employers, from family members during that first few weeks is critical, so that once they on effective treatment, the side effects will settle down. And I think that's the first important thing. The second, I think, also is that when you look at the success rate, Lindy has indicated like we have 80% success in drug-susceptible TB. When you look at clinical trial data, it's actually even higher. It's closer to 90-95%. So what we know is that the treatment is highly effective at curing patients. But there's other issues around the treatment. As I mentioned, side effects is one. And I think also the motivation. And what's very fascinating when you speak to survivors of TB is that self-motivation and conviction that they'll cure TB. Now, TB ambassador is fantastic. From all of us sitting in the panel today, I think he looks the healthiest of us all, right? He really looks solid. So, I mean, it's curable. I mean, that's the key message. And if you take your treatment, the success is unbelievably great.
Yeah. Talk about adherence. I mean, we're talking now comparing adherence to HIV medication and TB. So in those that are co-infected, where there's good adherence to HIV medication, is adherence to TB medication a problem?
Yes, it is in some instances, and in some patients, adherence to ARVs becomes a problem, but they take TB treatment. One of the challenges that we face is the stigma as well, because what we were promoting is that the adherence groups or support groups should address both HIV and TB, but that doesn't seem to be working well because of stigma. And that's one thing that we probably need to address, because it's a huge problem, and especially if we want to get people who are out in the communities who have TB, particularly even the contacts of people who have TB. They tend to shy away from people who are coming to the households to actually screen them, because we're sort of bringing attention to that home, around HIV or TB.
I know we've spoken about some of the social ills, associated with TB, but what's the importance of nutrition in those that are affected by TB?
It's very important. You cannot underestimate it, and obviously that's why we mention poverty, because while we encourage people to do that, to find the resources to do that, it's not an easy thing. But it is important for the well-functioning of every other person's body and their immune system.
Then the last thing we haven't spoken about is hospitalization. I mean, who gets hospitalized and why?
Obviously, it depends if it's what the TB has done to the body. So if you have TB and you're ambulant and we know you'll take treatment, it's easier to take it from home. But there are other things that could be affected, like if Thabo tells you he was bleeding and there was blood coming out, we're worrying that you can bleed to death, so we keep you to try and control the bleeding, and then you then go. If you have, for instance, TB in the brain, you have TB meningitis, it's better in the acute phase to treat you in hospital, and then when we know you're getting better and you are awake, you have regained your consciousness, then we can let you go. If you have side effects of the medication, for instance, like liver failure or kidney failure, it's better to be done in a hospital setting, and then you go. So, and other extra pulmonary manifestations, if you have TB in the adrenals, for instance, your blood pressure will be knocked. So as a result, it's better to be in a setup where we can observe that. So it's really the other things, but in the main, we treat them from home.
That's the message, to say in the main, in the majority of cases, people that contract TB can actually successfully be treated out of hospital so long as they adhere to treatment obviously everything else being equal. Well, Dr. Muromisi Mukansi, Prof. Nazir Ismail, and Dr. Lindiwe Mvusi, thank you so much for your time.
Pleasure.
And I hope that people out there have enjoyed this and found it very, very useful. And a whole lot of people will now, think about this condition and go out and screen and encourage others to prevent and screen. Okay. Well, thank you so much for watching, and we're back on the screens again next week, same time. And I'm Dr. Salome Dong, and until that time, please do take care.